It is a pleasure to introduce him today. Many of you know him incredibly well since he's been with us almost 7 years now. Prior to that, he was a gopher and heavily recruited to our residency program. We're so pleased when he matched here for residency and then stayed for fellowship. If you look at Matt's CV, which I won't do, it's very, very extensive. It's actually a little frustrating as someone who's been at this a lot longer to see our CVs be very similar in length. But I think it speaks to his hard work and dedication to scientific inquiry, as well as education. He was raised by an educator, and it really shows. He is one of the most awarded educators who's ever come through our residency and fellowship. And I know how beloved he is because so many of you in this room and online petitioned for me to hire him. And while I appreciated those very gentle suggestions, sometimes the power of move is to send your absolute best and brightest out into the world to represent our institution. That said, he's going to be very, very missed, and I look forward to hearing his talk today.
Speaker.
Okay. We just talk, or is there?
It's the
Oh, I go to. Okay.
ambient microphones.
Right. Well, thank you for that. Thank you for having me today. My name is Matt. As discussed, I'm one of the Gynecologic fellows. I'm going to be discussing several advancements in the management of gynecologic malignancies over the last few years, with specific attention to how these advancements may create or exacerbate certain care disparities for our patients. I have no relevant disclosures. These are the objectives here for our discussion today. After describing new advances in the treatment, evaluation, and management of gyn cancers, we will discuss specific examples of existing disparities and inequities at risk of exacerbation. First, we'll summarize mitigation strategies and action items to prevent growth of gaps in gynecologic cancer care. So mortality from gynecologic cancers is changing. Over the last 50 years, we've made great progress in reducing morbidity and mortality related to gynecologic malignancies, but this wealth of progression has not been well shared. Here you see data from the US SEER database highlighting improvements in mortality rates for ovarian cancer with relative stagnancy of cervical cancer. Notably, uterine cancer mortality has continued to worsen over the last 50 years. And as of 2024, uterine cancer has outpaced ovarian cancer as the deadliest gynecologic malignancy, with over 13,000 deaths in the United States annually. Looking more closely at uterine cancer, worsening mortality is largely attributed to a rise in aggressive non-endometrioid histologies like serous and carcinosarcomas. Even more concerning, while the rise in incidence of these histologies is relatively constant for white persons, Black, Hispanic, and Asian women are experiencing a more rapid rise in the incidence of these classically aggressive cancers, with Black women experiencing a 3.5% increase at an incidence nearly triple that of white women. Uterine cancer is not alone in this. While cervical cancer mortality has remained relatively constant, gains in cervical cancer prevention and risk reduction made from Pap screening, co-testing, and HPV vaccination have been affected since the onset of the pandemic. Data here demonstrates changes in cervical cancer screening through the pandemic. In orange, Hispanic women across multiple age groups experienced a more dramatic decline in cervical cancer screening completion without returns to pre-pandemic baseline rates compared to non-Hispanic white counterparts. Disparities in healthcare are new to no one, and they're certainly not new to cancer patients. The National Cancer Institute highlights opportunities for cancer care interventions and innovations across the cancer care continuum. Shown here is that continuum highlighting our understanding of an individual cancer diagnosis from etiology to detection through treatment and survivorship. Each step in this process invites opportunities for improving cancer prevention and cancer care. And at each point of this process is also full of opportunity for disparate care to creep in and affect how we care for people at risk for or living with gynecologic malignancies. Our understanding of how cancers begin and develop, what genetic and environmental contributions to carcinogenesis, awareness of preventative strategies, or options for diagnostics are all fraught with inequity, and much of our level 1 data is informed by experiments in homogeneous populations. Since I started my training, a practice-changing trial or manuscript has been published, altering the standard of care for many gynecologic malignancies roughly every 6 months. Each of these interventions, immunotherapy, targeted therapies, less radical surgery, more radical surgery, have all changed the landscape of cancer treatment, and each of them has introduced new hurdles for patients most at risk of being left behind by these advancements. More data from SEER shown here, demonstrating that even in the presence of practice-changing interventions, certain groups of people are at risk of being left out of guideline-concordant treatment. Data displayed here depicts a cohort of ovarian cancer patients in the US broken down by race and ethnicity. In general, guideline-concordant treatment is high. However, persistent disparities in receipt of guideline-concordant care exist for Black women, where roughly 10% of Black women in this cohort receive guideline-concordant care. Considering all comers, Black women are less likely than white or Hispanic women to receive any ovarian cancer care at all. Whenever we make changes to the way we care for a group of people, someone with a certain disease, someone who needs a specific type of procedure, or a group of people at risk of developing a certain condition, we introduce the opportunity to improve the process of providing care, and we also introduce the opportunity to make it worse. In general, our healthcare system, like many systems, continues to advance the needs and intents of those it's designed to benefit: people with private insurance, people with time, and people with money. Across therapeutic and surgical domains, we will talk about new treatment modalities and how to curb gaps in care, and we'll touch on how screening as it relates to genetically high-risk patients continues to lag behind in equitable completion of germline and somatic testing. In the last 10 years, immunotherapy has taken off for gynecologic malignancies. Prior approvals for the use of immunotherapy, both with chemotherapy, other targeted therapies, and alone, have largely occurred for patients with recurrent or incurable disease. In the last 3 years, immunotherapy has moved to the front line, and now for many endometrial and cervical cancer patients, immunotherapy is a component of standard of care, curative intent, primary treatment. 2 trials in endometrial cancer paved the way for the use of immunotherapy in the frontline setting. First, the RUBY trial, published in 2023, compared the use of dostarlimab with carboplatin and paclitaxel for advanced metastatic or recurrent endometrial cancer in a randomized placebo-controlled trial, demonstrating an improvement in progression-free and overall survival, most profoundly seen in patients who were defined as mismatch repair deficient. Similarly, GY018 compared the addition of pembrolizumab to carboplatin and paclitaxel for a similar population of advanced endometrial cancer patients, demonstrating very similar results, with the greatest benefit identified in a mismatch repair deficient cohort. Following these publications, NCCN quickly adopted carboplatin paclitaxel with immunotherapy as a standard of care Category 1 recommendation for patients with stage 3 or 4 endometrial cancer. The utilization of immunotherapy as an adjunct therapy for endometrial cancer rapidly increased and moved to the front line. To back up a bit, immunotherapy exploits a negative feedback system utilized by the immune system to essentially turn the immune system on and trigger activation against neoantigens expressed on tumor cells. Shown here is a schematic of a tumor cell expressing neoantigens. When these antigens are recognized by T cells without a signal from the expressing cell, the T cell is activated and destroys the cell, assuming there's a defect or reason this antigen is being expressed and recognized. Cancer cells upregulate expression of PD-L1 or programmed death ligand 1, which interacts with PD-1 expressed on T cells. This interaction of PD-L1 and PD-1 effectively turns off T cell activation and allows the expressing cell to persist. For cancer cells, this is a means of immune escape. Immunotherapy, sometimes referred to as checkpoint inhibition or checkpoint inhibitors, interrupts this inhibitory handshake of sorts by blocking either PD-1 or PD-L1, allowing T cell activation and apoptosis to occur. So here in this figure, this anti-PD-L1 little red antibody thing is your immunotherapy. Cancers that are more prone to immune infiltration, like cervical cancer, endometrial cancer, colorectal cancer, or head and neck cancers, have shown great promise in the utilization of immunotherapy. With the success of immunotherapy in endometrial cancer, its use has moved largely into the primary setting, as mentioned. Prior approvals for the use of immunotherapy for recurrent or metastatic disease include use of immunotherapy alone, with chemotherapy, or combined with other targeted medicines like lenvatinib. But again, across all these cancer settings, we see the greatest effect in patients with mismatch repair deficient tumors. So what is a mismatch repair deficient tumor? Mismatch repair proteins are DNA repair proteins with correct single nucleotide mismatches in DNA. When these proteins are functioning properly, base pairs that are paired up wrong or mismatched are correctly excised and replaced by the correct base. When this mechanism fails, owed to mutations or silencing of these genes, mutations in DNA begin to pile up. Commonly, these mutations are mismatches occurring in tandem repeat regions of DNA referred to as microsatellites. Many of us are familiar with microsatellite stability and instability, and this can be thought of as the genetic effect of loss of one or more of these repair proteins. So as mentioned, this concept is important due to its prognostic and therapeutic significance, particularly for patients with mismatch repair deficient endometrial cancers. And now you might be wondering, how do we assess this clinically? So currently in practice, there are 3 different means for assessing mismatch repair status. Most commonly, immunohistochemistry stains for these common MMR proteins, MLH1, MSH2, MSH6, and PMS2, are performed on endometrial biopsies or hysterectomy specimens for endometrial tumors. The benefit of this method is its reproducibility, its ease of implementation, and generic availability of these IHC stains across multiple institutions. Using PCR, mutations found in common tandem repeats can similarly assess for microsatellite instability, which correlates to mismatch repair deficiency. Shifts in these 5 domains, NR21, BAT26, BAT35, NR24, and MONO27, all correlate with increasing mutational burden in microsatellites, suggesting instability here. Microsatellite-based assessments may be a better indicator of how well immunotherapy is expected to perform for patients with endometrial cancer, and I will come back to that thought shortly. Lastly, next-generation exome sequencing can detect mutations per megabases across a variety of tumor tissues and histologies. Sequencing of a large panel of genes extracted from tumor specimens and then analyzed for a number of mutations identified per megabase reveals a tumor mutational burden, which also functions as a marker of mismatch repair proficiency or microsatellite instability. This is fairly time-consuming and expensive, and so this is not routinely obtained for these purposes. So this is where it gets kind of interesting. So this is a series of patients from UCSD that were treated with immunotherapy for recurrent endometrial cancer. Each line represents an individual patient, and the longer the line, the longer the benefit that was derived from the immunotherapy. The bright orange demonstrates patients deemed microsatellite unstable or high and mismatch repair deficient by PCR and IHC respectively. The maroon lines represent a patient that was MSI high and mismatch repair proficient, meaning the protein repair machinery is intact and functional, but their tumor was fairly mutated. The darker blue and yellow lines correspond to patients who were microsatellite stable and mismatch repair proficient or deficient, respectively. Due to discrepancies in expected response assessment between mismatch repair status, the authors concluded that microsatellite-based assessment of immune therapy function may better identify a population that stands to gain the most benefit from immunotherapy. Now, with that in mind, we can look at the data that exists regarding how, beyond these biomarkers, immunotherapy can affect patients most at risk of negative outcomes from an advanced endometrial cancer. Except we can't really. Both of these phase 3 trials where immunotherapy gained primary approval for advanced endometrial cancer under-enrolled Black patients despite rising mortality and incidence for these folks. Only 2% of all the patients with mismatch repair deficient tumors identified as Black in either of these trials. This trend is not new, and many cancer trials struggle with enrolling diverse populations, as many clinical trials occur and are conducted in idyllic conditions, often not reachable by diverse groups of people. Here you can, across all 3 of the gyn cancer sites I'm discussing today, and breast cancer, see that enrollment for Black women is pervasively lower. All right, well, what about mismatch repair testing? Why did I explain all of this protein testing to you? Well, the way in which these initial biomarker evaluation studies and the subsequent validation studies that were conducted in these groups of almost exclusively white people, therefore making any ability for us to infer differential performance of immune therapy across patients from different racial and ethnic backgrounds impossible. Within this data shown here, only non-Hispanic white women were included for analysis, and thus our understanding of best ways to assess the benefit of immunotherapy outside of a homogeneous group is very limited. Enrollment and biomarkers aside, these trials have opened up immunotherapy as a really promising option for many patients with endometrial cancer. I'm not here to just say that new therapies suck, but to present you with a critical way of thinking about how these therapies might introduce new barriers to care for people commonly left behind by the healthcare system. Another domain to consider with new cancer therapies is side effects or adverse events. In the RUBY trial, patients receiving immunotherapy in combination with chemotherapy for advanced endometrial cancer had a 10% higher chance of experiencing a serious adverse event compared to placebo, with a doubling of those adverse events attributed to dostarlimab. Side effects for immunotherapy are not benign. As many of the residents know, immunotherapy-related toxicities can show up wherever, whenever, kind of like Shakira. Common side effects like rash, hypothyroidism, diarrhea can be transient, but more serious side effects, including hepatitis, adrenal failure, pneumonitis, myocarditis, colitis, can persist and lead to treatment discontinuation, hospitalization, and death. Monitoring and visits for immunotherapy are not that much different than someone receiving chemotherapy alone, but management of side effects can be intensive and include topical oral steroids, hospital admission for high-dose steroids, and involvement of specialists for long-term management. The ability to manage and continue immunotherapy through treatment can be extrapolated from these clinical trials, but only for the patients enrolled. In the absence of a diverse cohort of patients and those from urban or rural communities with varying levels of economic support, our understanding of how to best support patients outside of some of this data is limited and needs to be considered when implementing an intensive therapy such as this one. Furthermore, we need to be cognizant of how patients are expected to be able to afford and the cost strain of novel interventions. Shown here is a scatter plot demonstrating cost-effectiveness simulations for dostarlimab versus liposomal Doxil for recurrent uterine cancer. Generally, you should see a clustering of each of these dots representing a simulation near the left side of the graph and below the $100,000 mark. However, this data is relatively spread out, and dostarlimab averages out at an ICER of $300,031,913 per quality of life year gain, which by universal standards is too costly. It's too much money. For immunotherapy to be considered cost-effective, a $15,000 infusion of dostarlimab or pembrolizumab would need to be a third of the price that it is right now. And these findings are similar across many different instances of the use of immunotherapy in the neoadjuvant and recurrent setting. To switch gears slightly, immunotherapy has not only changed the management of endometrial cancer, but cervical cancer as well. Where immunotherapy has been used in conjunction with chemotherapy for recurrent or metastatic cervical cancer, the addition of immunotherapy to definitive radiotherapy and radiosensitizing chemotherapy has developed within the last year. Pembrolizumab has been approved for the treatment of PD-L1 positive, persistent, recurrent, or metastatic cervical cancer for a few years now, but its indication for use as a primary adjuvant therapy with radiotherapy is based off the recently published KEYNOTE-A18 trial. A18 was a phase 3 placebo-controlled randomized control trial that randomized patients receiving definitive chemo-RT to adjuvant immunotherapy or placebo. Both disease-specific and overall survival were statistically increased with the combination, and again, rapidly, NCCN and the FDA supported and approved the use of pembrolizumab with definitive chemo-RT for stage 3 and stage 4 cervical cancer patients who express PD-L1. This is a little different than our approvals in endometrial cancer, which demonstrated benefit for somatic changes in those cancers, as specific assessments of PD-L1 testing have been employed in cervix cancer immunotherapy for some time. To determine benefit for the addition of pembrolizumab to cervical cancer treatment, a combined positive score, or CPS, is obtained. CPS involves physically counting the number of cells that stain positive for PD-L1 and roughly dividing this by the number of viable cells seen in the entire stain. This is fairly straightforward, reproducible, and surprisingly, there's not a great degree of inter-observer variability reported in the literature. A CPS score of 1 or greater is considered positive, meaning one cell that stains positive for PD-L1 in a group of 100 viable cells has qualified that person for potential benefit from immunotherapy. One of the reasons that immunotherapy has found a success in cervical cancer and head and neck cancer is that HPV infection induces expression of PD-L1. Often cancer-contributing strains of HPV, particularly ones that express E6 and E7, induce PD-L1 expression via viral interferon induction. This naturally leads us to conclude that the majority of cervical cancers that are found to overexpress PD-L1 are HPV-related and therefore highly preventable. However, viral induction of PD-L1 expression is similarly a phenomenon documented exclusively in tumor samples obtained from white people and suffers from similar setbacks to mismatch repair testing. For many years, the incidence of cervical cancer among Black and Hispanic women has been significantly higher than white women, owed to inequity in access to preventative measures like Pap screening, HPV vaccination, and inadequate follow-up for abnormal screening results. Non-white patients present more commonly with advanced disease and disease that is not curable with surgery or radiotherapy. Even when curative intent treatment modalities are employed, survival is often worse, particularly for Black and Hispanic women, as shown here. Timely completion of radiotherapy is a major contributor to survival outcomes in patients with locally advanced cervical cancer. Treatments lasting longer than 56 days or experiencing frequent interruptions to radiation portend a worse prognosis and worse survival. While Black women are more likely to experience worse survival outcomes when treated with radiotherapy for cervical cancer, efforts to minimize treatment interruptions and complete radiation with particular attention to completion of brachytherapy has the ability to equalize outcomes for patients. Shown here on the left are survival probabilities. Both figure A and C demonstrate worse survival for Black patients who do not complete radiotherapy on schedule and do not receive brachytherapy. When compared to figure B and D on the right, which demonstrate timely completion of treatment and the utilization of brachytherapy, survival becomes similar for all groups. So what does that mean for immunotherapy? Well, as mentioned, current disparities in survival and incidence of cervical cancer exist, and the biomarkers that we utilize for identification of benefit of immunotherapy are limited in the same way that they were in endometrial cancer. With added infusions, new side effects to address, and the risk of treatment interruptions, without information as to how to mitigate or manage in a diverse group of patients, the risk of treatment interruptions, lack of guideline concordant care, and need for post-marketing surveillance mean that cancer practitioners need to stay vigilant to ensure that adjuvant immunotherapy is benefiting everyone in the way that we hope it is. Trials evaluating immunotherapy as a primary therapy in the absence of chemotherapy are underway and are already utilized readily in other malignancies. Addressing these gaps before they widen further is crucial. So moving on to new targeted therapies approved in gynecologic cancers, several novel antibody drug conjugates have been approved for gynecologic malignancies within the last few years across several different disease sites. Antibody drug conjugates are a novel systemic therapy composed of three separate parts. The first, an antibody that targets a specific protein, usually a cell surface protein, is bonded via a cleavable linker to a high-potency chemotherapy that's often referred to as a payload. Antibody drug conjugates, or ADCs, function similar to a Trojan horse. Once bound by the cell surface protein, that cell takes the ADC into the cytoplasm where that linker is cleaved, releasing the payload. Then this typically induces cell cycle arrest and DNA damage, leading to cell death. In doing so, ADCs aim to deliver high potency and otherwise toxic chemotherapy in a directed manner to cancer cells that overexpress the target of interest. Three specific ADCs have gained approval for gynecologic cancers, the first of which is tisotumab. Tisotumab is the first ever ADC approved for a gynecologic malignancy and targets tissue factor, which is often expressed on a variety of epithelial cells. Tisotumab was initially approved following a phase 2 study several years ago. However, in 2024, a phase 3 comparative RCT of tisotumab versus physician's choice chemotherapy for second or third line cervical cancer patients demonstrated significant improvement in overall survival for patients that received tisotumab, which is good. You might say, wow, tissue factor is a common protein. Lots of things utilize tissue factor. And you would be right. Tissue factor is widely expressed in many cells, not just cancer cells. And then you might say, well, I thought you just told me that this medicine works by specifically going after cancer cells. And you would still be right. But also it goes after many other things, unfortunately. And common side effects of tisotumab include nausea, neuropathy, bleeding from everywhere, and ocular toxicities. Moving on to mirvetuximab soravtansine, an ADC approved for use in platinum-resistant ovarian cancer and now representing a new standard of care for patients with platinum-resistant ovarian cancer that overexpress MERV's target, folate receptor alpha. In the MIRASOL trial, mirvetuximab was compared to physician's choice chemotherapy and demonstrated a 4-month improvement in overall survival over chemotherapy, which is impressive because this group of cancers is extremely hard to treat. Mirvetuximab requires folate receptor testing prior to use, and tumor samples need to express folate receptor alpha at a proportion of 75% or more to be eligible to receive this medication. Common side effects of MERV include GI disturbances, neuropathy, and again, ocular toxicity. And lastly, following the results of the phase 2 basket trial, Destiny Pan Tumor 2, trastuzumab deruxtecan, sorry, it's just funny. Trastuzumab deruxtecan was approved for recurrent cancers that overexpress HER2. Many of us are familiar with HER2 as a biomarker utilized for many years in breast cancer. However, this has since expanded into endometrial carcinoma, particularly serous cancers, and other disease sites like gastric cancer. Trastuzumab deruxtecan is an ADC targeting HER2 and requires either 2+ or 3+ IHC staining to be considered efficacious. The Destiny trial is a basket trial, included many patients with many different types of tumors, including ovarian, endometrial, and cervical. Shown on the graph on the left in varying shades of green are endometrial, cervical, and ovarian cancer patients and differing degrees of response to trastuzumab deruxtecan, all of which are impressive when compared to other disease sites, which you see in other colors up there. For many HER2 3+ endometrial cancer patients receiving trastuzumab deruxtecan, median overall survival was extended past 2 years, which is unprecedented for a recurrence treatment in this setting. So now we have 3 new targeted therapies across a variety of different disease sites available to our patients facing recurrent cancer diagnoses, which is awesome because these cancers are tough to treat and often we're left with minimal efficacious options. But diving into the preclinical and clinical trials leading to these various approvals, we come across a few familiar issues. Folate receptor testing is determined based on IHC staining, and similarly determining the percentage of positive cells expressing the receptor. While preclinical studies have largely examined this again in a non-diverse cohort of patients, post-approval cohort studies have examined the expression of folate receptor alpha in a diverse cohort of patients. Data presented in abstract form at SGO this year suggests that up to 2/3 of patients who do not identify as white may be found to overexpress folate receptors and may be eligible for the receipt of mirvetuximab. However, despite that these approvals and integration into clinical trials is based on preclinical data that does not represent these diverse groups of people ultimately diagnosed and treated for these cancers. So we have the patient population, they're not making it into the clinical trials, and that is pervasive. Data for HER2 assessment is not much better. HER2 testing is completed similarly by IHC staining, and in cases of equivalence, reflexive FISH testing is performed. However, trastuzumab deruxtecan's approval utilized a testing algorithm that was adopted from gastric cancer, and once again, data is largely derived from samples obtained from white people. The lack of incorporation of specific tumor site testing into this algorithm is challenging, given the study is a trial that includes many disease sites. And the intention behind utilizing the gastric-based scoring system is that it is the most lenient in terms of classifying patients as HER2 positive, ergo creating more opportunities for patients to receive this new therapy. However, HER2 expression varies across the native tissues, and differing patterns of expression, like expression along a basement membrane or the opposite along an apical membrane, can have different implications depending on the tissue the receptor is expressed in. So whatever your tissue is, wherever the HER2 is overexpressed, that can be normal or not normal. So to take one specific tumor tissue and apply it to all cancers isn't going to work at some point. As such, disease-specific algorithms are needed, and those need to be validated in patients with different tumor histologies and amongst a diverse cohort of people. HER2 expression is more frequently observed in Black patients with uterine cancer, as HER2 expression is more often observed in serous carcinomas, and thus relatively the proportion of Black patients enrolled in trials evaluating trastuzumab is higher than other therapies in endometrial cancer. However, relatively the rates of enrollment still lag behind incidence for the disease. Going back to the first figure, as its incidence continues to rise in serous and serous-like histologies, Black women are more likely to be disproportionately affected compared to non-Hispanic white women. Under-enrollment of diverse patients into trials evaluating biomarkers overexpressed in serous cancers will undoubtedly make this application of this data challenging for those who need it most. And beyond just our understanding of differential expression and action of these medications in diverse groups of patients is our lack of understanding of how to best support patients often disenfranchised by our healthcare system through a relatively intensive therapy. As mentioned previously, each of these ADCs comes with its own set of side effects, some more severe and time-intensive in the management than others. Both tisotumab and mirvetuximab carry a risk of ocular toxicity. This requires a baseline examination by an ophthalmologist and subsequent examinations every other cycle. With both of these medicines, daily eye drops and sometimes steroids, treatment interruptions, emergency evaluation are necessary. And not to mention that when these medications prove to be efficacious against a cancer, they're often continued until progression, which effectively can be the remainder of that person's life. Trastuzumab deruxtecan similarly requires specific monitoring for cardiac toxicity and pneumonitis, which is a life-threatening side effect of trastuzumab that can occur in up to 10% of patients that receive this. Taken together, this amounts to a significant symptom burden that can detract from the person living with cancer's life. To describe this cost to patients' time, the concept of time toxicity has been introduced. And time toxicity refers to time spent coordinating treatments and visits to a healthcare facility. This includes travel time, wait times, urgent and emergency care, hospitalizations, testing, and rehabilitation. You can imagine that for someone living with an incurable cancer whose goal of therapy is to maximize length of life, but also to maximize quality of life, this can present a challenge in decision-making. When presented to patients, almost universally, many elect for strategies that involve cancer treatment when possible, but also those that increase days outside of healthcare interactions. When considering the ADCs discussed and their respective side effects and time toxicities, all phase 3 trials report higher rates of treatment adherence and patient quality of life and satisfaction. However, due to lack of diverse representation in each of those trials, our ability to understand how a patient receiving one of these therapies outside of the majority in our healthcare system is designed to support might vary. Different people are supported differently by their families, their communities. They may have different financial resources or social support available to them that make these time-intensive treatments tolerable and acceptable. In the absence of diverse validation cohorts and patient-reported outcomes from a non-generalizable population, the likelihood that these medications stand to benefit a specific type of person living with a specific gynecologic cancer is high. One proposed solution to time toxicity is telemedicine, of which research has taken off since the onset of the pandemic. If you have any questions, you can talk to Rachel after this presentation. Still, disparities in the utilization of telemedicine exist, and despite high interest from various racial and ethnic groups. Consistently, Black patients are less likely to receive or complete telemedicine visits for endometrial cancer management or surveillance when able. Inclusion in both our understanding of the problem and its solution are necessary to make forward progress. This figure shown here is from NYU, and it shows likelihood of telemedicine visit completion for endometrial cancer patients at their community partner cancer centers. And this is including all patients who had access to internet, access to technology that allowed them to participate and complete in telemedicine. And still these rates of completion and referral to telemedicine were much lower. Okay, so the last targeted therapy I wanted to touch on again is PARP inhibitors. PARP inhibitors are a class of medications that target poly-ADP ribose polymerase and are utilized as a maintenance medication following completion of primary or recurrent therapy for ovarian cancer. Many trials have evaluated the use of PARP inhibitors in this setting and have found that the greatest effect of PARP inhibition is limited to patients with BRCA-mutated tumors or tumors that are homologous recombination deficient. And again, these trials do not represent the subset of patients diagnosed with or treated for these cancers. This is data from a project Rachel and I worked on as residents that's abstracted SEER data, demonstrating PARP inhibitor clinical trial enrollment compared to proportions of patients diagnosed with ovarian cancers. You can see that both Hispanic and Black patients are underrepresented in these trials. This phenomenon is interesting because when offered, both Black and Hispanic women faced with a choice between maintenance and a non-maintenance surveillance path-based strategy would prefer a maintenance option if available, suggesting the desire to participate is there. The enrollment of diverse populations in clinical trials for gynecologic cancer is essential for counseling regarding the implications of new technologies and targeted therapeutics such as PARP inhibitors for racially and ethnically diverse groups. Furthermore, a failure to understand differences in metabolomics, side effects, and tolerance of novel therapies compounds the issue of enrollment and leads to a paucity of individualized information that's crucial for informed consent regarding trial participation for diverse groups. One reason for this under-enrollment and lack of receipt is due to lack of referral and completion of genetic testing for non-white patients diagnosed with ovarian cancer. While many Black patients who complete referrals for genetic counseling express interest in and complete genetic testing, many studies have reported significantly lower rates of completion of somatic testing when compared to white patients. Additionally, perceived barriers reported by oncologists often lead to delays or lack of genetic counseling referral and represent an opportunity for quality improvement initiatives to create equitable referral practices. Again, increasing utilization of telemedicine services to reach patients remote from testing centers or specialty services can be crucial to addressing this gap. Okay. 15 minutes. All right, lastly, I want to discuss several changes in surgical management of gynecologic cancer in the last few years. We will highlight 2 trials specific to surgical management of cervical cancer and 2 ongoing trials regarding surgical management of ovarian cancer. So many of us are already familiar with changes to management of early stage cervical cancer that occurred following the publication of the LAC trial in 2018. Radical hysterectomy remains a standard of care for early stage cervical cancer, not involving the vagina, parametria, or lymph nodes, at least not obviously. For a while, this procedure was being performed via a minimally invasive approach, which until the LAC trial had not been prospectively validated in a randomized fashion. However, the LAC trial, which randomized patients to minimally invasive versus open radical hysterectomy for early stage cervical cancer, was terminated early due to significantly worse disease-specific and overall survival effect identified in the minimally invasive group. Quickly, the standard of care shifted to open radical surgery for management of these cancers, and still when radical hysterectomy is indicated, minimally invasive approaches should only be considered in the setting of a clinical trial. Following the LAC trial, things got a little muddier regarding how to best manage early stage cervical cancer patients. In 2023 and 2024, the CONSERVE and SHAPE trials were published. Both trials sought to evaluate the non-inferiority of simple hysterectomy compared to radical hysterectomy for early stage, low-risk cervical cancer. Both trials were slightly different. The SHAPE trial was a randomized phase 3 trial, where CONSERVE was a phase 2 single-arm prospective cohort study. They had very similar inclusion criteria as seen here with some key differences. Notably, LBSI was allowed in SHAPE and not in CONSERVE, and CONSERVE stipulated that margins after an excisional biopsy needed to be negative to consider conservative management with simple hysterectomy. Both of these trials found that simple hysterectomy was safe with very low, less than 3% disease-specific survival at 3 years. 3% of people that, 97% of people were alive at 3 years without disease. In SHAPE, patients undergoing simple hysterectomy experience fewer postoperative complications and better sexual health compared to radical hysterectomy patients. The tricky thing about this, though, is that because the LAC trial, the SHAPE trial, and the CONSERVE trial all accrued and occurred patients in parallel to one another, both SHAPE and CONSERVE did not specify a specific surgical modality to be used, and thus both open and MIS patients were included at the surgeon's discretion in both of those trials. Thus, applying this data in the context of MIS radical hysterectomy being inferior to open radical hysterectomy is challenging, and many surgeons are engaging in frank discussions regarding the uncertainty in decision-making about surgical approach when simple hysterectomy is indicated. Thus, NCCN again adopted conservative criteria into the guidelines, and simple hysterectomy for early stage, low risk cervical cancer was added as a new option for management for this group of patients. Since the publication of LAC, many different groups have evaluated effects of MIS on survival outcomes in cervical cancer. Notably, a significant portion of patients in some parts of the world and country still undergo MIS procedures for early stage cervical cancer. Across all racial groups, this results in a detrimental survival effect. However, surgical modality does not fully explain differential outcomes in survival, as Black women who undergo open radical hysterectomy experience the same worse overall survival that white women do when they undergo MIS radical hysterectomy. This suggests that modality alone does not explain differences in cancer outcomes for patients with early stage cervical cancer, which makes sense. A similar trial attempting to answer this question in ovarian cancer is the LANCE trial. Currently, this is a phase 2 single-arm study evaluating the feasibility of MIS interval debulking after neoadjuvant chemotherapy. The LANCE trial recently met its accrual goal and is now moving on to a randomized phase 3 trial where patients will be randomized to laparotomy or MIS interval debulking after neoadjuvant chemotherapy. And the schema for that is shown here. However, our current standards do not provide equal opportunity for salpingectomy or MIS to all. This is data that we have from Meritor when we evaluated our postpartum salpingectomy rates a few years ago. You can see that more commonly, patients with Medicaid receiving tubal ligation procedures are those that would receive complete salpingectomy with private insurance. And at the time of cesarean delivery, this data that is taken from a large national database of the NISQIP sample Data here suggests that Black women desiring permanent contraception are less likely to receive self-injectomy and are more likely to experience tubal ligation procedures as a form of permanent contraception and risk reduction, which many consider to be inferior to self-injectomy for preventing ovarian cancer. And furthermore, when we flip the clinical scenario, non-white women are less likely to undergo medical management or tubal sparing procedures for the management of ectopic pregnancies and are significantly more likely to receive self-injectomy as a management strategy in the setting of desired fertility preservation. In this data obtained from the national inpatient sample, non-private insurance similarly conferred this same risk. The last trial I wanted to talk about is the SOROC trial, which is being conducted for patients with BRCA germline mutations at high risk of ovarian cancer. This trial is enrolling patients after age 35 to age 50 with a BRCA1 mutation and allowing them to decide on risk-reducing surgery, either bilateral self-injectomy or bilateral self-oophorectomy. Patients are then followed for incident cancer diagnosis and when ready, complete oophorectomy at their own discretion if they underwent self-injectomy alone. The SOROC trial represents an important step forward in reducing morbidity of surgical menopause while also aiming to mitigate cancer mortality. The basis of the SOROC trial stems from NCCN and many other societal recommendations that BSO can be considered by age 40 for BRCA1 carriers and age 45 for BRCA2 carriers to reduce the risk of ovarian cancer. This data is largely derived from cohort studies conducted in North America, demonstrating that patients diagnosed with ovarian cancer were significantly younger when BRCA1 mutations were identified, compared to those with BRCA2 germline mutations. However, of the over 1,000 participants included in the cohorts that informed these guidelines, less than 10% identified as a racial or ethnic group that was not white. In the absence of an understanding of penetrance of these genes, which we know are equally prevalent across different racial and ethnic groups, application of these recommendations in clinical practice, let alone in a clinical trial, are limited and may impose surgical menopause on a person who's experiencing a blanket recommendation. Okay, 5 minutes. So thank you for bearing with me. Throughout this talk, I've highlighted several consistent areas where we can improve our understanding, application, and implementation of these novel approaches to gynecologic cancers. Improving assessment of biomarkers by validating and examining markers in diverse groups of patients is crucial to understanding and identifying targets that can benefit patients that need new therapies most. We need a massive overhaul of our genetic understanding of many of our cancers as to why certain histologies are more common in certain groups of people, and how does that inform the creation and the application of novel treatments for everyone. Enrollment into clinical trials needs to be socioeconomically and racially diverse, and mandates regarding enrollment proportions of various persons from many different backgrounds is needed. Patient-reported outcomes, considering how side effects, time toxicity, and general treatment tolerance are managed across differing communities and practice settings, will inform how to best scale interventions into practice. The guidelines we utilize to make recommendations for cancer prevention and risk management are based on white people almost exclusively, and that needs to change. Community engagement to increase registration of tumors, genetic testing referrals, and completion and disclosures regarding the limits and generalizability of societal guidelines are warranted. And lastly, all of this costs too much. Subsidies from the federal government, the state government, and pharmaceutical companies who spend as much money to gain approval for new therapies and then do not support those who cannot afford these therapies are desperately needed. So again, this is that cancer continuum figure that I showed you earlier at the beginning of this talk, and I consider you to find a point along it where you see yourself identifying, working towards, or fixing or preventing a new gap in care from forming. I've annotated it here with some ideas that I had while preparing for this talk, and if you see anything that jumps out to you, let me know. These are my references. Thank you.
I think we have a few minutes for Q&A. Does anyone have a question?
I have a comment.
Sure.
Yeah, that was an amazing lecture. This is Luther Gaston. I'm virtual today. I really appreciate that. It shows that we're producing residents and fellow graduates that have a concept of what the challenges that still exist in healthcare equity and inequality. So that I appreciate that so much, Dr. Wagar, and I'm so proud of you.
Thank you, Dr. Gaston.
Yes, go ahead, Steve.
Just, I mean, obviously enrollment of different populations is hard to do. Do you know of any examples that have been successful to enroll different diverse populations in clinical trials?
So I think that things that have been successful are things that involve any type of community engagement. So whether that's clinical trial navigators, people that we partner with in the community, things that have been really successful, because obviously, let's say there was a mandate to enroll a certain racial ethnicity proportion per cancer center in the United States. And that's not going to work for everybody because not everybody's patient population is diverse. But looking at the proportion of the patients that you serve and what is the proportion of patients that you're enrolling and what is the proportion of patients that you see every day, how do you make that match up? Because obviously that's not going to be feasible for many cancer centers. The ways that is done really effectively is with using clinical trial navigators, using patient-reported information, educational handouts, things like that that involve patients in designing those clinical trials so they can say, this is the information that I don't understand. This is the information that gives me pause. This is something that's specific to my experience with the healthcare system or my family's experience, my friend's experience, whatever, that then you can go into making informational interventions, with languages with multiple cultural considerations, things like that have been successful. To my knowledge, it's not been scaled into trials, but for example, with the HER2 stuff, there have been some phase 1 studies because a lot of patients that have HER2 cancers that are Black, most of their cancers that overexpress HER2 also have KRAS mutations. Whenever we're using trastuzumab and HER2, you rely on that pathway, that KRAS pathway being able to be shut off. So if somebody has an activating KRAS mutation and you give them trastuzumab or some trastuzumab equivalent, and they have that KRAS mutation, it's not going to do anything. And so people have tried to look into ways to identify patients that are at risk for having these somatic changes based off of demographic backgrounds, things like that, and work that into sort of highlight that in unique populations. But that has obviously, that's not scaled to a randomized level at this point. So most of it is community engagement. Most of it is cancer centers employing or finding ways to carve out dedicated funded time for people to work within their clinical trials office, work within the community to actually bring people in and feel like they have a point person. Because a lot of this just stems from mistrust, which I didn't really get into because there's a lot to talk about here, but yeah.
Thanks.
Yeah, I just want to, again, congratulate you on covering, this is kind of like the landscape, like what's new in GYN oncology, but with at a really high level. So really super appreciate that. And then I just want to make 3 comments. Clinical trials and clinical innovations and bringing them into practice is just the passion of my career. And you were about to say that that Black and other disadvantaged populations, Black persons and other disadvantaged populations are mistrustful of the system, and it's well-founded. And I think everybody in this audience knows that. And so sort of trying to get over those barriers is just going to be sort of continuous work. But there's 2 things that you didn't include in your talk that I just want to say out loud. And one is that there is a body of literature that if historically disadvantaged populations participate in clinical trials, they have better outcomes. And it's a pretty good body of literature. And the second is that all populations, all races, all ethnicities, all people of all different sociodemographic backgrounds have better outcomes across the board if they participate in clinical trials. So I think that barrier of, oh gosh, I don't want anybody investigating or experimenting on me, I think that that's well founded in minority populations and frankly in white populations in this country. There's a lot of mistrust of medicine, but I think that concept of people who participate in clinical trials actually in cancer, on the whole, have better outcomes, I think is a message that, that's important for our communities.
I don't have access to the chat. I wonder if there's other questions.
There's a comment.
I'd like to also just real quickly say that we need to also be looking at endocrine disruptors within poor communities and African-American communities. I do have a former resident at the University of Chicago in G1 Oncology, and she's part of a lawsuit as an expert looking at Black women's hair chemicals, particularly formaldehyde-based hair chemicals, and they're linked to endometrial cancer. And so that one of the things, the norm in society is for Black women to kind of conform to the hair norms in jobs in places that they work or go to school. And so that, in addition, recently, there may be some carcinogens in some of these hair weaves and things like that that they also use. And so I think looking at some of the endocrine disruptors that are within the community is one way to eventually start to see, are there environmental influences to some of these serous cancers of the endometrium and things like that.
Thank you for that. There's a very smart comment in the chat that I don't know if you want to read. It has a lot of good words.
Sure. Carol Mullen had said that yesterday she attended a seminar, Optimizing Open Research, that was described as population conscious analysis focusing on social demographic variables which are used pervasively across research. This is appropriate when used to assess inclusion and described study populations. However, such variables are also used as predictor variables. This practice is so frequent, it is nearly automatic, yet it is deeply flawed. Dr. Enders will illustrate this with the race variable. Race is not a biological variable as such. When we reflexively include race as a predictor variable, it inadvertently acts as a proxy for differences often observed by race within our society. Current analytic practices risk developing clinical calculators and other models that include race, ethnicity as a predictor variable, thereby embedding structural racism into both research and the medical practices that evolve based on research. Population conscious analysis defines new analytic best practices to resolve this conundrum.
Thank you for that, Carol. I think that's a really important point because I do think there are pieces of this from a cancer landscape that do need to be investigated biologically, and we need to find ways to completely approach it differently from a systemic racism standpoint and the social implications. And those actually are two very distinct pathways, probably are both really important to understand for carcinogenesis and cancer treatments, but lumping them together does a huge disservice to our patients. So thank you, Carol. Thank you for attending that seminar. That sounds amazing. We have about 5 minutes. Oh, go ahead.
No, you don't have 5 minutes.
We don't, we have no time.
We probably have time for one more.
There's time for one more. I meant a 5-minute break, but there was one more question, so let's do it.
I'm sorry, so one question I have, so patients like to talk to people who look and sound like them, like, do we have any data on the navigators, study coordinators, the race and ethnicity of them when they enroll patients?
Yeah. The most successful interventions employ and utilize patients and patient navigators that look like them. They know they're people from their community. Usually they're patients themselves that have gone through a treatment and said, I want to make this better for somebody else who has my experience or didn't know about this or didn't know that this preventative strategy, this new therapy, this clinical trial office existed. So a lot of times that attempts to be concordant with the group of people that you're trying to bring into the system. And that is the most effective way, at least in the literature, to get that accomplished. There's varying degrees about the provider and whether or not that person needs to be racially concordant with their patients. You know, from a sex standpoint, are they the same sex? Are they the same genders? Do they identify that way? That has mixed messages. Most people kind of say they don't really care if they feel like they trust the person. So, which is hard when you are seeing a lot of really complicated people at a high volume, because a lot of the reasons that trust then erodes is often related to time on both ends, both patient and practitioner. So.
All right, let's start. That was amazing. Thank you for a robust discussion.